Welcome to today's explainer. So, you know the drill. A patient walks in with a musculoskeletal complaint. It's incredibly common, right? It literally accounts for up to 25% of outpatient visits. But let's be honest, sometimes figuring out exactly what's going on feels like searching for a needle in a haystack. Well, master clinicians don't just guess. They filter. They use precise physical maneuvers and even adapted telehealth observations to rapidly narrow the field. In this explainer, we're going to build a bulletproof algorithmic approach to joint pain. We'll start way up top with the macro-physical presentation and funnel our way all the way down to the microscopic level. Our goal? To make absolutely sure we never miss a critical diagnosis.
Here's our clinical roadmap. First, we'll establish the algorithmic diagnostic framework. Then, we'll cover spotting clinical red flags. After that, we'll hit the synovial fluid analysis rules, and finally, we'll dive into identifying microscopic crystal arthropathies. Let's get right into it.
Section 1. The Algorithmic Diagnostic Framework. Okay, to formulate an accurate differential, and frankly, to avoid ordering a bunch of unnecessary tests, we rely on 4 essential pillars. We have to ask ourselves, is the pain articular or non-articular? Is the process inflammatory or non-inflammatory? Is this an acute or chronic issue? And finally, what's the distribution? Is it localized or widespread? Answering just these 4 questions takes a vast, overwhelming sea of potential conditions and shrinks it into a highly manageable list.
Let's tackle that first pillar. How do you instantly distinguish true joint pathology from an issue in the surrounding structures? Well, it all comes down to the physical exam and range of motion. Articular structures, the joint capsule, synovium, cartilage, when those are diseased, the patient will have this deep, diffused pain. Crucially, their range of motion will be limited whether they move the joint themselves, active motion, or you move it for them, which is passive motion. You're also going to see swelling or bony enlargement. Non-articular disorders, on the other hand, involve the extra-articular ligaments, tendons, or muscles. These usually present with point tenderness. It hurts when they move it actively, but, and this is key, not passively. If you move the joint for them, it often doesn't hurt. So we use targeted maneuvers. For instance, true hip joint pain is felt deep in the inguinal groin and gets way worse with rotation and adduction. If the pain is on the side of the hip, you're likely looking at trichenteric bursitis, or maybe it's medial knee pain from pes anserine bursitis. By the way, even on a telehealth televideo exam, you can observe a lot of this. Watch their gait, check out a seated rise, assess their cervical range of motion, and always ask for contralateral comparisons. For nerve and tendon issues, we use things like Finkelstein's test, Durkin's test, or look for a Tinel's sign to isolate the problem without systemic joint swelling.
Once you know it's articular, the next question is it inflammatory? The specific duration of stiffness and how it responds to physical activity are your best clues here. Inflammatory disorders like rheumatoid arthritis often come with systemic symptoms, warmth, erythema, but the absolute hallmark is prolonged morning stiffness. We're talking stiffness that lasts for over an hour and, paradoxically, actually improves as the patient gets up and gets moving. Non-inflammatory conditions like your standard mechanical wear and tear osteoarthritis present with what we call a gel phenomenon. The stiffness is brief, usually under 45 minutes, and it reliably gets worse with physical activity. It definitely doesn't get better.
6. That number is your chronological dividing line, specifically 6 weeks. We use this precise cutoff to differentiate an acute presentation from a chronic one. Acute arthropathies, so anything under 6 weeks, tend to be infectious, reactive, crystal-driven, or even drug-induced. Think about things like fluoroquinolone or steroid-induced tendinopathies. But if a condition persists past that 6-week mark, we move into the chronic category. That usually points us toward long-standing immune-mediated issues or chronic degenerative conditions.
Finally, for our macro framework, we just count the joints. It sounds simple, but quantifying the involved joints narrows our diagnostic possibilities tremendously. 1 joint? It's monoarticular. Think infections or gout. 2 or 3 joints? That's oligoarticular or polyarticular, which usually shares a similar etiology to the monoarticular stuff. But if 4 or more joints are involved, it's polyarticular. That strongly shifts our suspicion toward widespread systemic inflammatory conditions.
Section 2. Spotting clinical red flags.
Now that we have our macro framework, we absolutely must identify the immediate limb-threatening emergencies. You can never, ever miss these 4 red flag diagnoses when a patient presents with acute focal musculoskeletal pain. Septic arthritis, acute gout, fractures, and vascular ischemia. These are urgent. They have to be diagnosed promptly to avoid severe morbidity and permanent joint damage. Basically, if a patient presents with a hot, swollen, acute monoarthritis, you have to assume it's a red flag until proven otherwise. And proving otherwise? Well, that usually means we need to get a sample from inside the joint itself.
Section 3. Synovial fluid analysis rules.
When an acute red flag is suspected, arthrocentesis is mandatory, and the lab results from that fluid are basically a cheat code. These exact white blood cell thresholds separate a simple, harmless effusion from a highly dangerous septic joint. So, normal synovial fluid is really viscous. If you drop it from a syringe, it forms a long string. In non-inflammatory conditions, the fluid stays clear, it's highly viscous, and the white blood cell count is low, under 2,000. But in the inflammatory category, the fluid gets turbid, it turns yellow, and it loses that viscosity. It just drips like water instead of stringing. Plus, the cell count jumps to anywhere between 2,000 and 50,000. Now, if that fluid is opaque and purulent, with a white blood cell count over 50,000 and a massive predominance of PMNs over 75%, you are dealing with a septic joint until proven otherwise.
Section 4. Identifying microscopic crystal arthropathies. Okay, what if the white blood cell count points to massive inflammation, but there are no bacteria? We zoom in even further under the microscope. Let's talk about monosodium urate, or MSU crystals. Look for their distinct, sharp, needle-like shape. When we view them under compensated polarized light microscopy, they exhibit bright, negative bifringence. They often glow this brilliant yellow when parallel to the compensator axis. You can find them floating around extracellularly or literally inside the immune cells trying to clear them. This distinct visual signature is the classic, definitive hallmark of gout. And as a quick aside, keep an eye out for this in the hospital because acute gout can often be precipitated by things like diuretics or chemotherapy.
Now contrast that with calcium pyrophosphate or CPP crystals. These look completely different than the sharp needles of gout. These crystals are much shorter, often rod-like rectangular or distinctly rhomboid-shaped. Under polarized light, they are weakly positively birefringent, often appearing blue. When you see these blunt rhomboid shapes, you've hit the nail on the head for pseudogout, formerly known as calcium pyrophosphate deposition disease.
This visual dichotomy is an absolute must-know. You have the sharp, negatively birefringent needles of gout on one hand, and the blunt, positively birefringent rhomboids of pseudogout on the other. Identifying these precisely doesn't just give you a satisfying diagnosis, it actually dictates an entirely different long-term management strategy for your patient. It's a real game changer.
I want to wrap up this explainer with a really provocative reminder from the source text. What happens if you look under the microscope? You find those classic needle-shaped crystals of gout, and you just stop your investigation there. Well, you might be making a fatal error. Crystal-induced arthritis and septic arthritis can, and occasionally do, coexist in the exact same joint at the exact same time. Finding crystals absolutely does not give you a free pass to ignore a dangerously high white blood cell count or skip the bacterial culture. Whether you're carefully observing a patient's seated rise over a telehealth call or analyzing fluid under a microscope, it really is the ultimate test of the master clinician. Always keep your investigative guard up, trust your diagnostic funnel, but never let finding one answer blind you to another. Thanks for joining me for this explainer. Keep filtering the noise, and I'll catch you next time.